I need to tell you something that might save your life, or the life of someone you love. Right now, millions of seniors are being treated for high blood pressure using guidelines that were never designed for them, and the consequences are devastating. I'm Dr. Rebecca Lane, and I've spent 15 years in cardiovascular medicine watching what happens when we apply one-size-fits-all numbers to bodies that don't fit the mold. What I'm about to share comes from research so recent that most physicians haven't adjusted their practice yet, and that delay is costing lives. Let me be direct. If you're over 70 and your doctor is pushing your blood pressure down to 120/80, you need to understand something critical. That target, the one we've been told is ideal for everyone, might be slowly destroying your independence. It might be setting you up for a fall that changes everything. And here's what makes this so frustrating. The evidence has been hiding in plain sight. We just weren't looking at the right populations. For years, the medical establishment has operated on a simple premise: lower blood pressure equals better outcomes. And for middle-aged adults, that's largely true. But aging changes everything about how your cardiovascular system works. Your arteries stiffen, your pressure sensors slow down, your body's ability to compensate for sudden position changes deteriorates. Yet somehow, we've been treating 80-year-olds like they're 50, and the results have been catastrophic. Before I go any further, I want you to do something. Think about whether you get lightheaded when you stand up. Does the room tilt for a second? Do you grab for the wall or the furniture? If that's happening to you regularly, what I'm about to explain could be life-changing. Drop a comment with just the word dizzy if this sounds familiar. I need to understand how widespread this problem really is. Let me tell you what happened to a woman I'll call Sandra. She was 79 when her daughter brought her to my clinic. 6 months earlier, Sandra had been completely independent, active, sharp, living alone and loving it. Then her doctor decided her blood pressure of 150/86 was unacceptable. He started her on medication with one goal in mind: get her to 120/80. After 3 months and 2 different drugs, they got there. 122/76. Textbook perfect. That's when Sandra's world started falling apart. First came the fatigue. She felt drained all the time. Then the dizziness started. Every time she stood up, the world would spin for a few seconds. Her doctor told her this was normal aging. Drink more water, he said. Stand up slowly. Sandra did everything right, but the dizziness got worse. Then one morning, she stood up from bed to use the bathroom. Her blood pressure plummeted. Her knees buckled. She went down hard and shattered her hip on the corner of her nightstand. Hip fracture at 79. You know what that means. Emergency surgery, weeks in rehab, loss of independence. But here's the part that still haunts me. Sandra never fully recovered. The fear of falling consumed her. She stopped moving, stopped going out. 6 months after that fall, she developed pneumonia from being sedentary. Her body couldn't fight it off. She died in the hospital with her daughter holding her hand, all because someone pushed her blood pressure to a number that was perfect on paper, but lethal in reality. Sandra's daughter said something to me I'll never forget. My mother was fine until they fixed her blood pressure. How does fixing something kill a person? And that's the question we need to answer. How did a perfect number become a death sentence? Here's what your doctor probably hasn't told you. The guidelines that define 120/80 as ideal came from studies of people in their 40s, 50s, and early 60s. Researchers observed that lower pressure in these age groups reduced heart attacks and strokes over time. That data is solid. But then we made a catastrophic assumption. We assumed the same targets would work for everyone, regardless of age. We were wrong. A massive study just published in the Journal of the American Medical Association followed over 15,000 adults above age 75, real-world seniors, people with diabetes, prior strokes, frailty, not the carefully selected subjects from earlier trials. And the findings flipped conventional wisdom on its head. The seniors who lived longest and maintained the best quality of life had systolic pressures between 130 and 140, not below 120. The group with pressure under 120 had significantly higher rates of falls, fainting, kidney problems, and death. Think about that. The people we pushed to textbook perfect numbers died sooner than those we left at moderately elevated levels. The researchers dug into why, and the physiology makes perfect sense once you understand what aging does to your cardiovascular system. Your arteries are supposed to be elastic. When blood pulses through them with each heartbeat, young flexible vessels expand and absorb that pressure wave. This cushioning effect means you can maintain good blood flow to your brain and organs even at relatively low pressures. But arteries don't stay flexible forever. With each passing year, they stiffen, They lose their ability to expand and contract. Medical term is arteriosclerosis, and when vessels are stiff, you need slightly more pressure to push blood through them effectively. Now imagine you're 78 with stiff arteries, and your pressure is 120/80. You're lying in bed. Blood is reaching your brain just fine because you're horizontal. Then you stand up. Gravity pulls blood downward. Your brain is now the highest point in your system. In a young person, sensors in the blood vessels, called baroreceptors, detect this pressure drop instantly. They signal the heart to beat faster and vessels to constrict. Pressure stabilizes within seconds, but baroreceptor sensitivity declines with age. They respond slower, much slower. So when you stand, your pressure drops before your body can react. Your brain gets less blood. You feel dizzy. Your knees weaken. You fall. This is called orthostatic hypotension. And if your baseline pressure is already at 120, you don't have much cushion. When gravity pulls blood down and your slow baroreceptors can't compensate fast enough, your pressure might drop to 90, 80, even 70 systolic. That's not enough to perfuse your brain adequately. You're going down. Sandra's blood pressure lying down was 118/74. Standing, it crashed to 82/54, a 36-point drop in systolic. Her brain was being starved of blood every time she stood. The medications had worked exactly as intended. They lowered her pressure, but they lowered it to a level her aging body couldn't handle safely. Comment your age and your typical blood pressure reading if you're comfortable sharing. I'm trying to get a sense of what people are running and whether these targets are being applied appropriately. Just numbers. No need to explain. Here's another factor your doctor might not be considering. Older adults metabolize medications differently. Kidney function declines with age. Liver function declines. This means drugs stay in your system longer and have more powerful effects. A dose that's gentle for a 50-year-old might be overwhelming for an 80-year-old, but we often use the same dosing protocols across all ages. The result is overmedication, blood pressure that's driven too low, side effects that are dismissed as aging, and then there's the risk calculation itself. In younger people, the danger from high blood pressure is cumulative damage over decades, heart disease, kidney failure, stroke from atherosclerosis. Preventing these outcomes makes sense when you have 30 or 40 years ahead of you, but when you're 80, the immediate risk from low blood pressure can be far more dangerous than the theoretical long-term risk from moderately elevated pressure. A fall can kill you in months. Blood pressure of 140/85 might never cause a problem in your remaining lifespan, so the equation shifts. For someone who's 50, chasing 120/80 is rational. For someone who's 80, preventing falls might matter infinitely more than hitting an arbitrary number. Let me introduce you to James, 73 years old, came to me with blood pressure of 148/84. His previous physician had started him on medication to bring it down. After 8 weeks, James was at 124/76, close to target. But James felt horrible, exhausted, foggy-headed, dizzy when he stood. His quality of life had collapsed. I looked at his overall health. No diabetes, no heart disease, kidneys working fine, active lifestyle. For someone like James, 148/84 probably wasn't dangerous, and the medications were clearly causing harm. We reduced his dose, let his pressure drift back up to 136/80. James came back 6 weeks later and said he felt like himself again. Energy restored, mind sharp, no dizziness. His pressure was higher than the guideline recommendation, but he was thriving, and 136/80 is not a dangerous number for a healthy 73-year-old. Now compare James to Ellen, same age, 73. But Ellen had diabetes, history of heart attack, reduced kidney function. For Ellen, 148/84 was legitimately risky. We needed to bring it down, but we couldn't go to 120. That would be too aggressive given her other conditions. We targeted 130/80, got her there gradually with careful monitoring. She tolerated it beautifully. No symptoms, no orthostatic hypotension, and her risk of another cardiac event dropped significantly. Same age, different targets, because they're different people with different risk profiles. This is what individualized medicine actually looks like. Comment your age and list any major health conditions you have, like diabetes, heart disease, or kidney problems. Just brief, something like 72, diabetes, or 68, none. This helps me understand what we're really dealing with. Let me tell you about Dorothy because her case illustrates the other extreme. 84 years old, frail, multiple chronic conditions, including heart failure and kidney disease. Her blood pressure ran around 165/90. Her primary care doctor wanted to lower it aggressively. I pushed back hard. For Dorothy, lowering her pressure could be catastrophic. She was already weak and unsteady, already at massive risk for falls. Driving her pressure down might tip her over the edge, literally. We left Dorothy at 160/90, higher than any traditional guideline would recommend, but Dorothy felt stable. No symptoms, no falls. She stayed independent. 5 years later, she's still alive and still in her own home. Her pressure has remained around 160 the entire time. If we'd forced it down to 120, I'm convinced she would have fallen, broken something, and died within a year. We chose safety and function over adherence to a number. But this isn't just about the very old or the very frail. Even relatively healthy seniors need higher targets than younger people. Take Robert, 70 years old, healthy, played tennis twice a week. Pressure was 144/82. His doctor wanted 120/80, but Robert felt great at 144. Lots of energy, active, no symptoms. I told him the truth. For a healthy, active 70-year-old, 144/82 is probably harmless. The benefit of pushing it lower would be minimal. The risk of medication side effects could be significant. Let's monitor it and leave it alone unless something changes. Robert was relieved. He didn't want more pills. We check his pressure every few months. It stays stable around 140. No problems. He's still playing tennis at 73. For him, this approach was exactly right. Now I need to explain something about the two numbers, systolic and diastolic. Systolic is the top number, pressure when your heart contracts. Diastolic is the bottom number, pressure when your heart relaxes. In older adults, systolic matters more. As you age, systolic tends to rise because of arterial stiffening. Diastolic often stays flat or even decreases. This creates what we call widened pulse pressure. The gap between the two numbers gets bigger. A 75-year-old might have 150/70, pulse pressure of 80. This is normal for their age. It reflects arterial stiffness. What you absolutely don't want is very low diastolic pressure. If diastolic drops below 60, blood flow to the heart muscle during the relaxation phase can become inadequate. This creates its own set of problems. So while we might accept systolic of 140 in an older adult, we want diastolic above 65, ideally 70 or higher. When Sandra fell, her diastolic standing was 54. That's dangerously low. Her heart wasn't getting enough blood during its resting phase. This contributed to her collapse. Let me talk about what happens in your brain when pressure drops too low. Your brain sits at the top of your body. Blood has to flow upward against gravity. Young people with flexible vessels and responsive pressure sensors handle this effortlessly, but older people with stiff vessels and sluggish sensors need adequate pressure to maintain brain blood flow. If systolic drops below 110 in an older adult, cerebral perfusion decreases. Not enough to cause immediate damage, but enough to cause symptoms: dizziness, confusion, fatigue, difficulty concentrating. These symptoms are subtle. People blame aging, but it's actually inadequate brain blood flow from excessively low pressure. Brain imaging studies have shown that seniors with very low blood pressure have reduced blood flow to certain regions. Over years, this could contribute to cognitive decline, memory problems, difficulty with complex tasks. Some researchers suspect overly aggressive blood pressure treatment in the elderly might be fueling the dementia epidemic. This is controversial. Not everyone agrees, but the possibility should terrify us. If we're accidentally causing cognitive decline by lowering pressure too much, we're doing enormous harm. Your kidneys also need adequate pressure to filter blood effectively. When pressure is too low, kidney function can deteriorate. This is especially true in older adults whose kidney function is already marginal. Studies show that aggressive pressure lowering in seniors sometimes triggers acute kidney injury. The kidneys simply can't work properly at very low pressures. So we're balancing multiple competing interests: pressure low enough to reduce stroke risk from hypertension, but high enough to maintain brain and kidney perfusion, high enough to prevent orthostatic hypotension and falls. That balance point is higher in older adults than in younger people. Let me give you specific numbers now. But remember, these are guidelines, not absolutes. Your personal target should be decided between you and your physician based on your complete medical picture. For adults 65 to 75 who are healthy and active with no major medical issues, a reasonable systolic target is 130 to 140, diastolic 70 to 85. This provides adequate perfusion while still offering cardiovascular protection. For adults 75 to 85 who are relatively healthy, a reasonable systolic target is 135 to 145, diastolic 70 to 85, slightly higher because of increased arterial stiffness and slower compensatory responses. For adults over 85, or for anyone who is frail regardless of age, a reasonable systolic target is 140 to 150, diastolic 70 to 85. The priority here is preventing falls and maintaining independence. The risk from slightly elevated pressure is lower than the risk from hitting the ground. For older adults with diabetes, prior stroke, or heart disease, targets might need to be a bit lower, perhaps systolic 130 to 135, but still not 120. And close monitoring for symptoms and orthostatic hypotension is absolutely essential. For those with chronic kidney disease, it gets complicated. Moderate pressure reduction can protect the kidneys, but excessive reduction can decrease kidney perfusion and worsen function. Targets need to be highly individualized, often aiming for systolic 130 to 140. Comment which category fits you, something like 65 to 75 healthy, or over 85 frail, or 75 to 85 with diabetes. I want to see the distribution. More important than hitting any specific number is avoiding orthostatic hypotension. This is the key. If your blood pressure drops significantly when you stand, that's a red flag. That's a warning that your pressure might be too low for your body, or your medications are too strong. Here's how to check at home. You need a blood pressure cuff. Lie flat for 5 minutes. Measure your pressure. Write it down. Stand up. Measure again immediately while standing. If systolic drops more than 20 points, or diastolic drops more than 10 points, you have orthostatic hypotension. For example, if you're 130 over 80 lying down and it drops to 105 over 68 standing, that's a 25-point systolic drop. That's orthostatic hypotension. That's dangerous. Even if 130 over 80 seems reasonable, if it crashes when you stand, your medications need adjustment. Sandra had severe orthostatic hypotension. Lying pressure 118 over 74. Standing pressure 82 over 54. 36-point systolic drop. That's why she was dizzy. That's why she fell. If someone had tested her for orthostatic hypotension, they would have caught it before the tragedy. They could have reduced her meds and saved her life. Let me tell you about Kenneth, 75 years old, pressure of 128 over 76. His doctor was thrilled, but Kenneth kept complaining of dizziness when standing. His doctor dismissed it. Your pressure is perfect. The dizziness must be something else. I had Kenneth do the lying to standing test. Lying pressure 128 over 76. Standing pressure 96 over 56. 32-point drop. Severe orthostatic hypotension. We cut back one of his medications. Lying pressure went up to 136 over 80. Standing pressure stayed at 118 over 70. Only an 18-point drop. Much safer. Dizziness resolved. Kenneth felt fantastic. His doctor was uncomfortable with 136 over 80. That's above guideline targets, he said, but Kenneth wasn't dizzy anymore. Wasn't at risk of falling, and 136 over 80 is not a dangerous number for a healthy 75-year-old. Function improved, quality of life improved. That's what actually matters. Here's the complete protocol for figuring out your ideal pressure. Do this with your doctor. First, check your pressure at home regularly, morning and evening. Keep a log for 2 weeks. This gives an accurate average. Office readings are often artificially elevated. Second, check for orthostatic hypotension using the lying to standing test I described. If you have a significant drop, your medications likely need adjustment, even if your resting pressure seems fine. Third, assess your symptoms. Are you dizzy, tired, foggy? These might signal pressure that's too low. Or are you symptom-free and feeling great? Then your current pressure might be fine, even if it's not textbook ideal. Fourth, consider your other medical conditions. Diabetes, heart disease, kidney disease, prior stroke. All of these affect your ideal target. Your number should be personalized based on your complete health picture. Fifth, have an honest conversation with your doctor. Bring your home pressure log. Bring your orthostatic test results. Bring your symptom report. Discuss what target makes sense for you specifically. Don't just accept a blanket 120 over 80 recommendation. Sixth, if you adjust medications, do it slowly, one change at a time. Monitor pressure frequently. Watch for symptoms. Check for orthostatic hypotension. Make sure the new plan is working before making more changes. Seventh, reassess regularly. Your ideal pressure might change as you get older. What's right at 70 might not be right at 80. Reevaluate every 6 to 12 months. Repeat the standing test. Make sure your current target is still appropriate. Let me address common questions. First, my doctor insists on 120/80. How do I change their mind? Show them the research. Print out the JAMA study. Demonstrate that for older adults, 130 to 140 may be safer. Most physicians, when shown the evidence, will reconsider, but some won't budge. If your doctor absolutely refuses to discuss higher targets, despite your concerns and symptoms, consider finding a new doctor. Second, I'm on 4 blood pressure medications, and I'm still at 145/88. Should I add a fifth? Maybe not. If you're over 70 with no symptoms and no orthostatic hypotension at 145/88, that might be perfectly acceptable. Adding another drug might cause more harm than benefit. Discuss with your doctor whether 145 is okay for you. Third, I'm 68 and healthy. Should I aim for 120/80 or the higher targets you mentioned? At 68, if you're healthy, 120 to 130 might still be appropriate. The higher targets are mainly for people 75 and up, or those who are frail. But even at 68, if you're having symptoms at 120, discuss a slightly higher target. Fourth, what if my pressure varies a lot? Sometimes 125, sometimes 145. That's completely normal. Blood pressure fluctuates throughout the day. What matters is the average over time. That's why a log is important. One high reading isn't a crisis. One low reading isn't necessarily a problem. Look at the pattern. Fifth, should I adjust my medications myself if I think they're too strong? Absolutely not. Never change medications without consulting your doctor. But if you're experiencing symptoms you think are from low pressure, make an appointment. Voice your concerns. Ask to reevaluate your regimen. Most doctors will work with you. Let me tell you what happened to Patricia, 77 years old. Her doctor had driven her pressure down to 116/70. Patricia felt awful, dizzy, weak, confused, struggling with daily tasks. Her son brought her to see me. I checked orthostatic pressures, lying 116/70, standing 86/52, severe orthostatic hypotension. We significantly reduced her medications, let pressure come up to 138/78. Orthostatic hypotension resolved, lying 138/78, standing 124/70, only a 14-point drop. Perfect. Patricia's symptoms vanished, energy returned, mind cleared. She felt like herself. Her previous doctor was upset we let her pressure rise so high, but Patricia was happy, functional, living independently, and 138/78 is not dangerous for a healthy 77-year-old. We chose function and quality over a number on paper. Let me also tell you about Arthur, 82 years old, pressure of 170/92, no medications, felt fine, no symptoms, but his son was worried. He'd read that high blood pressure is the silent killer. He brought Arthur to me. I explained that while 170/92 is higher than ideal, the question is whether treatment will actually improve his life or lifespan. Arthur had no history of heart attack, stroke, diabetes, or kidney disease. He was active and sharp. Starting blood pressure medications at 82 carries real risks. Side effects, dizziness, falls. The benefit might be small. We discussed options. Arthur wanted to try lifestyle changes first. Reduce sodium, increase potassium-rich foods, lose a few pounds, walk daily. 3 months later, his pressure was 158/86. Better. Still not perfect by traditional standards, but Arthur felt great. We decided against medications. Just continue the lifestyle approach and monitor. Arthur's son wasn't happy. He wanted pills, but Arthur was comfortable. He's now 85. Still independent, still active. Pressure around 155/86. No complications, no medications. For him, this was the right call. The key insight is that blood pressure management in older adults isn't just about numbers. It's about the whole person, their functional status, quality of life, other medical problems, fall risk, personal preferences. All of these matter. There's a concept in geriatric medicine called treat the patient, not the number. It means looking beyond lab values to consider what's actually best for this individual human being. Blood pressure of 145/88 might be too high for one 75-year-old and perfectly appropriate for another. Context matters. Individual factors matter. Comment treating me, not the number. If you felt like your doctor focuses only on lowering your number without considering how you actually feel, I want to see how common this experience is. Let me address dementia risk briefly. Some studies suggest high blood pressure in midlife increases dementia risk decades later. That's probably true. Chronic high pressure for decades damages brain vessels and raises vascular dementia risk. But other studies show very low blood pressure in late life is also associated with increased dementia risk. This makes sense given what we know about brain perfusion. If pressure is too low, the brain doesn't get adequate blood flow. Reduced flow over years could accelerate cognitive decline. The sweet spot appears to be moderate pressure in older adults. Not too high, not too low. For most people over 75, systolic in the 130 to 145 range seems associated with the best cognitive outcomes. Lower than 120 might increase dementia risk. Higher than 160 probably also increases risk. The middle range is safest. This is another reason blindly chasing 120 over 80 in all seniors could be harmful. We might be raising their dementia risk by reducing brain blood flow. There's also white coat hypertension. Some people have normal pressure at home, but elevated pressure in medical settings. Stress of the doctor's office raises it temporarily. If physicians only see the high office readings, they might overtreat. They might push pressure down to levels that are too low for that person's actual baseline. Home monitoring solves this. It gives a much more accurate picture of true average pressure. If you have white coat hypertension, your doctor can base treatment on home readings instead of office readings. And there's masked hypertension, the reverse. Normal in the office, high at home. This is dangerous because it might be missed. Home monitoring catches it. If office pressures are fine, but you suspect home pressures are high, check regularly at home and share those readings with your doctor. Here's the complete summary. This is what you need to remember and discuss with your physician. For most adults over 75, systolic blood pressure of 130 to 140 is associated with the best outcomes. Lower than 120 increases risk of falls, orthostatic hypotension, kidney injury, and possibly dementia. Higher than 150 increases risk of stroke and heart attack. The sweet spot is the middle. For adults 65 to 75, targets can be slightly lower. Systolic 130 to 140 is still reasonable. Some healthy 65-year-olds might do well at 120 to 130. But if symptoms develop or orthostatic hypotension appears, higher is better. For frail older adults, regardless of age, preventing falls is the priority. Targets should lean higher. Systolic 140 to 150 is often appropriate. Function and independence matter more than hitting a specific number. For older adults with diabetes, prior stroke, or heart disease, targets need individualization. Generally, systolic 130 to 140. Occasionally, lower if tolerated without symptoms or orthostatic hypotension. Close monitoring is critical. Diastolic pressure should generally stay above 65, ideally 70 to 85. Very low diastolic reduces blood flow to heart and brain and should be avoided. Orthostatic hypotension is often more dangerous than moderately elevated blood pressure. Check for it regularly. If present, medications likely need adjustment, even if resting pressure seems acceptable. Comment I understand if you followed all of this and grasp that blood pressure targets for older adults should be higher than traditional guidelines suggest. Comment talking to doctor if you're planning to discuss this at your next visit. After Sandra's death, her daughter filed a complaint with the state medical board, not out of malice, but because the doctor had been following outdated guidelines. He didn't know 120 over 80 might be too low for a 79-year-old woman. The board investigated, found no misconduct because he'd followed standard protocols, but the case prompted the board to issue new educational materials to all physicians in the state. Information about blood pressure targets in older adults, about the risks of overtreatment, about checking for orthostatic hypotension. Sandra's daughter told me, "I can't bring my mother back, but maybe her death will prevent others. Maybe other doctors will learn that lower isn't always better for seniors. Maybe other families won't suffer like we did." That's why I made this video, to spread this information, to help seniors understand their blood pressure targets should differ from younger people, to help you have informed conversations with your doctors, to prevent unnecessary falls, injuries, and deaths from overtreatment. If this information could prevent a fall, or help you have a better discussion with your physician, or improve your quality of life, please share it. Share with friends over 65. Share with your parents. Share with anyone on blood pressure medications who's experiencing dizziness or fatigue. This could save a life. Subscribe because my mission is delivering accurate, current medical information your doctors might not know yet. Guidelines change slowly. New research takes years to reach practice. I'm bringing you the latest science now, so you can make informed decisions about your health. Comment one of three things. 1. Too low if you think your blood pressure might be too low for your age. 2. Perfect if you think your pressure is in the right range after watching this. 3. Talking to doctor if you're planning to discuss changing your target with your physician. Bookmark this video. Come back to it. Review the target numbers. Review the orthostatic hypotension protocol. Share it with your doctor if needed. This could be a turning point in your blood pressure management. The moment you learned that higher might actually be safer for your age. Thank you for staying with me through this. You now understand the truth about blood pressure targets for older adults. You know 120/80 isn't right for everyone. You know the specific targets for different age groups. You know how to check for orthostatic hypotension. You know what to discuss with your doctor. Use this information. Advocate for yourself. And don't let anyone tell you one number fits all. I'll see you in the next video, where we continue taking control of your cardiovascular health together.